let me just finish up on those two other common heart problems seen in Loeys-Dietz syndrome. One is called an atrial septal defect, or ASD, but you may have also heard of it as PFO, or patent foramen ovale. They're actually pretty much the same thing. They are both holes in the heart that occur at the level between the right atrium and the left atrium. Now, those are the chambers up here in the upper part of the heart where the blood waits before it goes into the two pumping chambers. If you have a hole between those two, the problem is some of the blood on the left side of the heart that should be pumped out to the body leaks back through the hole and goes through the lungs again. So you end up with too much blood going through the lungs and through the right side of the heart. If the hole is big, the child can actually feel short of breath. If it's not that big, it can still damage the heart or the lungs from all that excessive blood flow for many years. So it depends really how big the hole is. And there are ways to measure that and also measure how much blood is actually going through it. And it has to be a pretty significant hole to warrant doing something about it. Many of these children also have this in addition to their aneurysm, so if we're there in the operating room taking care of the aneurysm, we close the hole as well. That's pretty straightforward. Now, if it turns out that there's a hole without an aneurysm, and you have to think about whether or not you should just go in and fix the aneurysm, then you have two options. One, and this is what these look like at the time of surgery. There's the hole. You can just sew it up. But there are also these new catheter options. A catheter that is passed up through the leg, and it can position these devices. We call them clamshell devices. They don't really look like clamshells, but the idea is that they kind of are plastic materials that are sandwiched across that hole and can block the hole up. And the body actually puts a layer of tissue over it over time, so it kind of heals in there. It's very attractive because it avoids open heart surgery, and it actually is highly successful. But I will tell you that we're not sure yet if this is the best way to treat this problem in people with connective tissue disorders. Because if the tissues are weak, this thing may not anchor in there as well as it should. We're keeping an open mind about it, but it's just like with stenting of aortic aneurysms. We're not sure that that's a good idea with when the tissues are not so strong. But you will hear about that. And then the other is this problem called patent ductus arteriosus. Now, when we're born, we're all born with a little blood vessel that connects the aorta to the lung artery, the pulmonary artery. That blood vessel is supposed to close off on its own, usually in the first week of life. I won't even go into why we're born with it, but it serves a purpose mainly when we're still in the womb. And it's supposed to close off on its own, but if it doesn't, it ends up letting some blood leak back into the lungs from the body. And just like with that ASD, you have too much blood going through the lungs, which can make you short of breath or damage the lungs long term. But it appears that these happen more commonly in people with Loeys-Dietz syndrome than the other people. So it comes up much more frequently that you have to think about having it taken care of. And the usual way is a short, simple operation to go between the ribs here, because it's actually way here in the back, and just tie it off or put a little clip on it. And it's very low risk, works extremely well. Is that right? Yeah. So, and by the way, this is what they look like in the operating room. Here's the aorta, here's the pulmonary artery, there it is right there. More often than not, we're looking at it from the side, and that's where, that's that little blood vessel there. Here's the aorta, and then the pulmonary artery is up in there. That's a little nerve there called the recurrent laryngeal nerve. That's a nerve that supplies the vocal cord on the left side, and it travels right next to the PDA. So when we ligate these, we have to be very gentle with that nerve, because if we injure it, the person can end up hoarse. That's the most common complication of this kind of surgery.
Same thing.
Yeah. So, as with ASD, there are ways to close these with catheters and putting little coils in them that make them clot off. very safe, very effective, but still, we don't know for sure if that's the best way to treat it in people with connective tissue disorders. So there you are. Those are the three main heart problems that we have to deal with in Loeys-Dietz syndrome. Aortic aneurysm, the root aneurysms, clearly the most important, clearly the most common. But these other two come up fairly frequently, so now you've got a little bit of a background on those. So to summarize, aortic aneurysm, and we're talking specifically about aortic root aneurysms, the most common life-threatening problem in Loeys-Dietz syndrome. Operations to prevent it, that is a preventative or prophylactic aortic root replacement. It's a safe and it's a life-saving operation. The valve-sparing operations, that is operations that keep the patient's valve as opposed to replacing it with an artificial valve. They avoid those problems of prosthetic heart valves and therefore are very attractive the younger the patient. And the late complications after this kind of surgery are probably a little higher than they are in Marfan syndrome, and that's one of the reasons why they need to be very carefully followed. You know, they're going to have scans for the rest of their lives to make sure that problems don't develop in other parts of the aorta. An atrial septal defect, a PFO, and PDA are common, but they're very, very straightforward to treat. We're just still not sure exactly what the best way to treat them is. So again, I thank you very much for your attention. I'd be delighted to handle any questions now. So the question is there a size limit by which one should decide whether to close a PFO or an ASD? And remember, PFOs are ASDs. They're just the small ones. It's more than semantics. The difference between a PFO and an ASD is if you're looking at that wall between the two atria in profile, with an ASD, there's a big gap like that. That's an atrial septal defect. There's a defect in the septum, the wall. A PFO is this. There's actually no tissue missing. It's just that whereas they're normally, these are overlapping and fused flaps, in a PFO, it's a potential opening. And it's sometimes hard to sort out ahead of time which one it is. I mean, you could tell if it's this, but telling whether the patient has no PFO versus a big PFO is actually very hard to know without being in the operating room. But you ask the question, is there a size that just says you got to have it done? And the answer is no. It's not actually the size of it, it's how much blood is going through it. Now obviously bigger ones are going to have a lot more blood going through them, and it becomes a no-brainer when it's, you know, the size of a quarter. But for the marginal ones, and there's some that are just so small, I mean it's a pinhole kind of thing, that's not a problem. For the ones in the middle, it's based on how much blood flow is going through it. And we can estimate that by echoes, by cath, or MRIs are actually wonderful ways to measure this now. And the rule of thumb, if the amount of blood going through the right side of the heart is more than 1.5 times what's going through the left side of the heart, it should probably be closed. The normal ratio is 1:1. It's the same amount of blood going through the right side as the left. But if the ratio is more than 1.5 to 1, it's probably the right thing to do to close the hole. Yes?
Thank you. With the PIG valve, are you pretty certain that within about a 5-year period it's going to have to be replaced?
So the question is, with a PIG valve, are you pretty sure it's going to have to be replaced in 5 years? The answer is no. It depends on the age of the patient. If you were 50 years old, but if you were 2 years old, it's highly likely that it'll fail within 5 years or wear out. I hate the word failure because it's not really failing. It's doing what it's supposed to do. It just doesn't last as long. It's pretty sure. But I'll tell you, there's so much variability in this. I've actually seen some PIG valves last in young people, like teenagers, 20 years. Well, that doesn't happen very often, but it does happen. So 5 years would be about average for a 2-year-old. Yes?
Thank you, Dr. Cameron. You mentioned for the 31 hospital patients that you have a 3.5 year mean follow-up. What exactly does that mean?
Well, it means that if you take all of those 30 patients, half of them actually have less than 3 years of follow-up. Their operation was done in the last 3.5 years, but the other half it was done more than that. It's a way of saying that on average we don't have 10-year follow-up on everybody. That's considered pretty short follow-up because, again, it's a new disease or newly recognized disease. Most of these operations have just been done in the last 3 or 4 or 5 years. That's considered midterm. In terms of follow-up, a medical study that has only a year follow-up would be called early results. If it's sort of 3 to 5, 7 years, it's called midterm results. And if it's more than that, we call them long-term results.
I was under, for a second, oh my God, that means within 3.5 years you're coming back to you.
No, I'm sorry. That just means that we have information about how they're doing for, on average, about 3.5 years. That's all it means. Sometimes it could be 5 years since the surgery, but we only saw them a year and a half ago, so we say that the follow-up was at 3.5 years.
My daughter actually has ASD, and she's 2.5. She has LDS. She's scheduled to have enclosed through a catheter. Is there they told us there were 2 different types of devices. There's like a soft kinetics type, which they said they would use, and then there's a harder one, which they said they won't use when they put too much pressure. Am I hearing this correctly? So we're going to use the hard metal type one and use the soft one?
Yes. In fact, one of the pictures I showed you here is the softer one. The one on the top up there is the softer one. It doesn't have much of a stiff rim to it, whereas these here on the bottom, which are the older types, are fairly stiff. The concern about this is that this thing sits in the atrium, but one rim of it is right up against the aortic root. And the worry is that anything that's too stiff and is right up against the aortic root could actually erode through it. So is that something we really should be concerned about? Nobody knows. We just don't know yet. But until we know more about it, it makes sense to put something that's not quite so stiff in it. It's intuitive, but it's not proven. Yes?
Would you rather see the patient go through the return or that you long-term effects?
I would say that at this point, I think a catheter closure is a reasonable thing to do. I'm not one of those people who says that because it's a connective tissue disorder, you shouldn't be putting these foreign materials in there. But I think we really have to be cautious about this. And the question that I would ask is, are we sure that hole needs to be closed now? Especially if you're starting to see some dilatation of the aortic root. It may be better to wait a few years and just not do anything about the ASD, see how things develop, because if it turns out that you're going to need an aortic root operation in 3 years anyway, maybe it's better to just leave the ASD and deal with it then. You see? But every child's going to be different in that respect. If you have a 2 or 3 year old who's got a completely normal aorta, well, it's not likely it's going to get big in 2 or 3 years. And if that child also has a big ASD, you probably should go ahead and get it closed by catheter. Great question. So the pulmonary valve and the base of the pulmonary artery, called the pulmonary root, it's always dilated in Loeys-Dietz syndrome and Marfan syndrome. It's always dilated. And it seems to progress, but I don't know of a single one that's ever ruptured. And I think the difference is that the pressure in that artery is much, it's 1/4 what it is in the aorta. Now, even though I've never heard of it rupturing in Marfan syndrome, if someone came along and they had one that was this big instead of this, I would say fix it. But I don't want you to be the first one in the literature. But we would not worry about them the same way.